Well, good afternoon and welcome to our February Caregiver Solutions event. I am Dana Cameron, Client Services Manager at Vantage Aging. This month, we will be discussing stroke education and prevention and are grateful to have our speaker here from the Cleveland Clinic. Thank you, Kayla, for organizing this, and thank you, Dr. Zalas, for being here. Dr. Elizabeth Salas is a neurology resident at the Cleveland Clinic. She is a Cleveland native who attended medical school at Ohio University, where she received the 2023 Specialty Medicine Award. Dr. Salas has a special interest in stroke and is particularly passionate about teaching stroke prevention to the community. Welcome. Thank you for being here.
Thank you so much for having me. I'm super excited.
Welcome.
So typically how I start this is, I don't know, Kayla, if people are able to do like a pre-test for this event. I don't think so.
We can skip that for this one, probably.
Okay.
Sorry about that.
No, that's okay. That's totally fine. It's all about, getting people the information regardless. So I can share my screen if it'll let me.
It should let you, yes.
Let's see. Is it going? Does it work?
Yes, it is. I can see it.
This bar would get out of my way. All right, perfect. So this presentation is brought to you by not just myself, but there's a lot of other people behind the scenes, lots of medical students. Dr. Johnny Dang, also one of my co-residents here, has put in a lot of time and effort in putting in, this presentation. So I'm just the one lucky enough to deliver it to you all. So are you able to see it all okay? Or is the fact that the Zoom on here, is that?
We can see it. It looks good. Yeah.
So something that we kind of start off with is just kind of getting, the neurons firing, what we might think all of these people have in common. And I think it would be a pretty safe guess if you said that they have all had strokes. So I think the most striking thing about this slide is just the the age range, that it doesn't discriminate in terms of, people who are super famous or, not so famous. It affects all humans to pretty similar degrees. So a little bit of an outline for the presentation today. We want to talk about what is a stroke, how does one recognize a stroke, what do you do if you see that somebody is having a stroke, what are the risk factors, and what we're really here for is how to prevent stroke, right? So starting off, what is a stroke? So basically what this slide is showing you is that each part of your brain has a primary responsibility. It's not all cut and dry like this nice little figure is here, but generally these areas are responsible for these functions. And if any part of the brain here were to stop receiving oxygen or start having an interruption in the blood flow, these are the things that would be ultimately affected. So, you have your motor function, your eye movement, muscle control, speech, your sight, of course, being able to understand language as well. So at any point, if these were to lose that oxygen, that would be, what gets knocked out. So this diagram is a nice little representation of the arteries that carry the blood to the brain, and that blood has oxygen that your neurons need to function. The brain is a very finicky organ. It likes what it wants and will let you know if it's not getting what it wants very quickly. And so this is just a little diagram that kind of shows you, the branches and the main arteries that are responsible for supplying lots of those structures. So A stroke is when blood is reduced or blocked, and that ultimately prevents the tissue from being perfused and from getting the oxygen and the nutrients that it needs in order to function correctly. And very quickly, brain cells become injured and they die if they are not receiving oxygen and nutrients. So there are two types of strokes. There's ischemic and hemorrhagic. And ischemic is defined by an actual clot that is blocking the flow. And hemorrhagic is like a rupture that causes like a bleed in the brain. And ischemic is far more common. It's about 87% of the strokes that we see. And hemorrhagic is much less common. It's about 13%. But unfortunately, they are more deadly. So I believe we have a little diagram later on that kind of uses an analogy of a flower and a pipe. So you can kind of think of it as, you know, a pipe going to the flower, giving it water. And if an ischemic stroke happens, there's something that would block that pipeline and that water stops being supplied to the flower. And the flower, of course, eventually dies. Hemorrhagic, there can be like a break in the pipe. And so the water leaves the pipe before it ever even can get to the flower. And so in that way, it's still being starved of the oxygen and nutrients. So something that I think a lot of people are also familiar with are TIAs, or transient ischemic attacks. A lot of people refer to them as mini strokes. But you know, that's not technically correct, just because the definition of stroke would require some sort of like changes on your imaging, like your MRI, your brain scan. So thankfully, TIA is defined as blood flow being cut off for a certain period of time, usually 15 to 30 minutes or less. And eventually your brain in your body is able to, you know, in whatever way, stop that obstruction and restore blood flow. And there ends up being no actual residual damage from a TIA. So if we took a picture of your brain and you had a TIA, then there should not be any evidence that there's been ischemic damage or lack of oxygen to any part of your brain. But just because it's a mini stroke or a TIA and it's not having any permanent lasting effects, that doesn't mean that it should not be taken seriously. It's actually a very important warning sign that a stroke may come and it may be worse the next time around. And your risk for stroke following TIA is fairly front-loaded, meaning that it's more likely to happen closer to the time that you're having TIA and TIA symptoms, as opposed to like several months following the TIA. So something that we always say in neurology is time is brain. Like I said, the brain is a very finicky organ. It needs what it needs. And if it doesn't get it, as you can see, you're losing millions of brain cells every minute after a stroke occurs. So as you can see, that little black area is representing dead neurons and dead cells. And if I were you, if you were me, I think we would all prefer that 10-minute block as opposed to that 6-hour block of cell death. So when thinking about stroke treatments, you can kind of think about it as, you know, like kind of the pipe analogy that I was using earlier, the types of things that you use at home to clear your pipes. It's not totally that much different. So for the most common thing that we use is a clot busting medication called TNK. And this must be given within 4.5 hours of stroke occurring. And, you know, this time frame is established after several years of trials and studies that show 4.5 hours is the safer end of the spectrum. Past that, you know, we get a little bit more risky in terms of risk and benefit, bleeding versus how much tissue are we saving after 4.5 hours. And this picture here is just a picture of the like the contents of a clot that could be responsible for causing a stroke that the medication ultimately targets. And then the other way, if you think about like snaking your drain at home, if it's clogged, is something called thrombectomy. And this has a much larger window. It can be done within 24 hours of stroke, and there are some things that are contraindicated, or you're not able to get that clot busting medication, TNK, but you might still be able to receive thrombectomy. It's got a little bit of a difference in terms of inclusion guidelines. So thrombectomy can be done within 24 hours, and it's just like it shows here. You have this like catheter that does go into the brain vessels, snags that clot, and can retrieve it. And as you can see, there's a nice, beautiful picture of a clot that was taken out through thrombectomy. And I love this picture. This is my favorite slide on the presentation. So you can see this is a vessel imaging of the brain, and you can clearly see that the blood vessels stop pretty abruptly right here, and they are not going and dispersing in that nice, beautiful, like tree-like pattern. There's something obscuring that, and therefore all of that brain that would have been perfused by that branch is no longer receiving oxygen or nutrients. But with thrombectomy, we are able to take out all of these clots and restore all of that vasculature that otherwise would have been lost. It's pretty amazing. Another stroke treatment, so this is often what we use for aneurysms, and aneurysms are a big cause for hemorrhagic stroke. So when they pop, it causes a bleed. And aneurysms can be treated one of two ways: either clipping it, as it's shown here, kind of just clips off that little bulge in the blood vessel, or it can be coiled. So we put this big, kind of knot of coiling in there, and then eventually that clots off, and it doesn't cause a problem after that. So how common is stroke? And unfortunately, it's fairly common. About 800,000 people a year have a stroke, and that's about twice the population of Cleveland. And there are approximately 7 million stroke survivors in the United States. And if you think about it, it's occurring about every 40 seconds, unfortunately. And 4 out of 5 families will be touched by stroke. I'm sure many of you are coming on board and listening because you or a loved one have been affected by stroke. And, I can say I personally, my loved ones have been affected by stroke. And so any way that we can prevent it, it would be great because these numbers are pretty staggering. And in terms of the seriousness of stroke, it is the 5th leading cause of death, and nearly 150,000 people die of stroke each year. And someone dies of a stroke every 4 minutes. And it's costing, our health industry $34 billion a year. It's a pretty significant cause of mortality, and your functionality is also fairly impaired as well. So even if people don't pass from stroke, a lot of them end up with very seriously disabling deficits that can take them out of a lot of things of their daily functioning. And so that's kind of what we talk about here. It's the leading cause of disability in the United States. And so all strokes, we like to say that all strokes get better to some degree. And it has a lot to do with, the size of the stroke, the severity of the stroke, and how motivated the patient is, with like PT and OT. So those smaller strokes can definitely have a much wider potential in terms of, improvement. Unfortunately, those bigger ones, we kind of have very modest improvement in those. But, these disabilities can be year-long, PT, OT, or it can even be lifelong, like I said, depending on the stroke. And the mobility is reduced in more than half of survivors, 65 and older especially, and it can absolutely be career ending. If you work with your hands and you lose function in one of your hands, or you're not able to walk, I'm sure a lot of you can imagine that would be pretty difficult to go about your day-to-day and completing your tasks. as, whatever your job is. So next in the outline, how do you recognize a stroke? The mnemonic that we use is called B FAST. B is for balance, E is for eye, F is for face, A is for arm weakness, S is for speech difficulty, and T is for time. So in terms of balance, if they're having sudden coordination problems, they're kind of like not able to point to something very like smoothly, or they suddenly start leaning to one side and they can't just like walk straight like they otherwise would. Or if they have like sudden onset, pretty severe dizziness, that could be a sign of stroke. Sudden loss of vision in one or both eyes or double vision, that is also very concerning for stroke. And then for the face, sometimes it can be subtle, but lots of times it can actually be fairly striking. People will just suddenly lose all function of the lower part of their face, and sometimes they'll even lose function in the upper part of their face. When they raise their eyebrows, like their one eyebrow won't even go. So that can be pretty striking to see, when somebody asks you for a smile and they can't really smile. And then in terms of arm weakness, if you ask them to raise their hand, one arm will be not going as high, or kind of will start to drift a little bit more. Speech difficulty, they'll either not be able to produce speech. They sometimes aren't able to understand speech. And then slurring of speech is also something that's pretty common in stroke. And then timing, the T is just to be a reminder of, time is brain, and you should call 911 as soon as you see one of these symptoms in people. So what do you do if somebody has a stroke? We kind of have talked about it, but call 911. It's super important to get these people to a doctor very quickly, get them the care that they need, and rule out stroke or rule in stroke, and get them the treatment that they need. So we have something called the Mobile Stroke Treatment Unit at Cleveland Clinic. It's really amazing. So, transporting patients to the emergency room, getting them into the scanner, and getting access to the medications, all of these things take time. And, like we have kind of been saying throughout this entire time, is that every second counts, every minute counts. So the fact that we can kind of bring all of that on the road with us to whoever might need it is really, it's pretty amazing. So what is the mobile stroke unit? So it is essentially all of those things in one. So they will be dispatched by 911, and the local ambulance will actually come out with them simultaneously and kind of do like the initial assessment. And then the mobile stroke unit arrives, they get handoff, they do point of care testing, like glucose, they can do a CT scan right there in the unit. And they get sent to a neurologist and a radiologist. And there's a virtual stroke neurologist there on a computer screen, telling, looking at the exam, telling the patient to do different aspects of the exam for them. And it can either decide, do they need this clot busting medication? Do they not? You can do vessel imaging with them as well. And then it triages them to the appropriate hospital for like further workup of stroke. So as you can imagine, it can be pretty significant in terms of time. I think this is a video of them. Can you hear that?
Stroke is a leading cause of death and the leading cause of disability.
With stroke care, every minute counts.
It's estimated that we lose about 2 million brain cells a minute.
I remember being really sleepy, and I remember one time kind of stumbling around.
You want to get treatment as fast as possible. Cleveland Clinic's Mobile Stroke Treatment Unit is an emergency room on wheels. When an EMS squad gets dispatched for a potential stroke patient, we get dispatched at the same time. If it does turn out that the patient is experiencing stroke-like symptoms, care will be handed over to us. This unit has all the tools available. The unique part of our truck is having the CT scanner on board. We can determine what type of stroke they are having, whether it be an ischemic stroke, which is when there is a clot blocking the blood flow to the brain, or a hemorrhagic stroke, which is when the artery ruptures.
Can you tell me where you are?
Our critical care nurse and paramedic will assess the patient, hook them up to our cardiac monitor, insert IVs, as well as draw the laboratory samples. Then we will bring in a physician virtually to examine the patient.
Hey, Dr. Uchino, this is a 61-year-old female. Stood up, started feeling like giving away of her right leg.
We can get into the vehicle via the telemedicine and see the patient and make their assessments.
Ma'am, how are you doing? Can you talk to her?
If there's any type of therapy to be administered, we will do it right there on scene.
TPAs and Tuesdays.
We have good evidence now for the use of intravenous TPA, which is the clotbuster medication. And we can use that medication up to 4.5 hours after the onset of a stroke.
We're actually seeing that we're saving 90 minutes of time by bringing everything to the patient.
This unit was first trialed in Germany in a couple of centers, but we're first in the United States to be rolling this type of program out. We were able to implement different aspects of what they had done, but also innovate and bring in new elements that would be useful in our healthcare system.
One of the unique things that kind of separates us from the German experience is that we have the ability not only to treat the ischemic stroke, but also to treat the hemorrhagic stroke as well. We are able to administer therapy right on scene much sooner than if they were to come into a hospital.
In the United States and around the world, people are looking at this type of model to see whether they can implement it in their own setting. It really does take an organization like Cleveland Clinic to bring together the resources and take the initiative to do this kind of project.
We're here because we want to provide this type of care out to the community that much faster.
I could be not talking to you at all. I could really be having crazy, those residual effects. Or I could be even not even alive.
I thought that was it, that this was the day that I was going to lose my grandmother. She has a second chance at life thanks to the people on the stroke unit.
It's exciting to be able to actually see that you're making a difference in a patient's life.
Yeah, so that's a really good overview of what our mobile stroke unit does. So other helpful information to know when you call 911 is something called the last known well. And this was the last time that the patient was seen, quote unquote, normal, totally at their baseline, how you would expect to see them on any given day. It is not when stroke symptoms were first noticed. So if grandpa goes to bed at 8 o'clock and he says, good night, we'll see you tomorrow, everything is totally fine, you don't notice anything strange, and then he wakes up at 8 o'clock the next morning, and all of a sudden the left side of his face is completely drooping and not working, the last known well is that bedtime. It's not when he woke up with those stroke symptoms. It's the last time that anybody saw him completely normal. Another thing that's super helpful for EMS is knowing their current medications, especially things like blood thinner medications. Common ones are warfarin, Eliquis, Xarelto. Those are medications that are super important to help us with clinical decision making, because depending on the last time they had a dose of one of those medications, it may mean that they are not able to safely receive something like a clot busting medication. It's all case to case basis. So knowing, how these people are, what these people are getting treated with at home is always super, super helpful. And then any relevant past medical history. Have they had a previous stroke? Have they had a heart attack? Was it recently? Any sort of like GI bleed, or recent surgeries, just anything that you can think of. It can be hard in a stressful situation to remember all of these details, but anything that you can recall is always super, super helpful, especially those medications and when the last time they got them. And then the next thing we'd like to talk about are the risk factors for stroke. But before we move on to that, I was thinking during the mobile stroke unit, I think I misspoke about the BFAST. For the F, the facial droop it would actually only, they should have preserved function of their eyebrows. They should not have inability to move their eyebrows. So moving on, how to talk about like stroke factors and things like that. So there are modifiable and non-modifiable risk factors. And so of course the modifiable risk factors are things like weight, being overweight or obese certainly increases your risk. Having high blood pressure is a very, very high risk for stroke. As a neurologist, we kind of like people to be their top number to be like less than 135. I know other specialties, they're a little bit more liberal in terms of their hypertension and their blood pressure preferences. Neurology likes to keep it tight because we know that it can certainly be a cause of stroke. Diabetes, smoking, of course, atrial fibrillation is another stroke risk factor. That is often, why people are on these blood thinning medications like Eliquis or Xarelto, is because they have this history of AFib. When the atria do not contract regularly and they kind of like, exactly what it sounds like, fibrillate, and they kind of quivers instead of a nice full contraction, that kind of sets it up for blood flow to kind of stay in one place and become stagnant. And that can predispose you to clotting. And when the clot forms, as soon as something, part of that clot breaks off, it can go straight up to your brain and cause strokes. Alcohol abuse. Alcohol in general has a pretty significant effect on the brain, even outside of just stroke alone. So being mindful of your intake is only going to be helpful for your health. And of course, substance abuse, especially things like cocaine. Cocaine can cause constriction of those blood vessels and cause pretty significant damage. But of course, all substance abuse is bad. IV drug use can set you up for pretty significant infection, and infection can actually cause, septic emboli is what they call up to your brain when you have a heart infection and it kind of starts to spit out parts of that infection up to your brain. These are all risk factors. And then having high cholesterol, LDL, that's why your primary care doctor's saying, we need to start you on a statin. It's one of the most commonly prescribed medications because this cholesterol level can certainly put you at risk for stroke. When somebody has had a stroke, we like to keep their LDL number less than 70 for prevention. And then sleep apnea is really, really huge. People don't understand how significant sleep apnea is. They think it's a little bit of snoring. They just kind of, push it aside, kind of like blood pressure. People don't really think of the consequences of blood pressure, but sleep apnea is associated with basically any health problem that you can think of. Sleep apnea is increasing your risk for it. It's pretty significant in terms of stroke risk factors, but even just risk factors for health problems in general. Increases your risk for high blood pressure, which of course then therefore increases your risk for stroke and cardiac pathologies as well. And then stress, as much as I would like to say stress can be totally modifiable, it's always hard to say, oh, just have less stress in your life. I know if somebody said that to me now as a resident, it would be like, okay. But, doing what you can to always know that your cup is filled, whatever makes you feel fulfilled at the end of the day. For me, it's like doing stuff like this, reaching out to the community to help kind of manage those stress levels. And then of course we have non-modifiable factors like age, gender, ethnicity, family history, personal history of like a stroke or a heart attack, and then things like sickle cell anemia. So these are the big things. Your PCP is the godsend that gets to see you once or twice a year, that looks at all those modifiable risk factors and says, okay, what can we do about that? And does their best. I promise they're not just trying to pick on you. I'd have some family that would say, oh, they care too much about this. It's not a big deal, but they are the front line in terms of prevention in health. And then prevention of stroke. As you can imagine, preventing those modifiable risk factors or optimizing those modifiable risk factors, that is your key to preventing stroke. So exercising regularly, even if that means just going on a little bit of a walk every day, walking your dog. I think people kind of have this preconceived notion that in order to consider themselves an exercise regularly, they need to have to go to the gym and do weights and do this and that. And that's not necessarily true. I mean, just getting your body moving in whatever way you are comfortable with and whatever way you can sustain is how you should exercise. I'm a big proponent. I feel passionately about that. And then eating a healthy diet, and doing your best to cut out those like fried foods, high salt intake. Same goes with smoking and alcohol. And then going to your PCP to get those regular checkups, because they're the ones that can check in on things like your blood sugars, to check you for diabetes. They can check in on your cholesterol, and they can look at your blood pressure and see, where have you been, and do we need some medications to help lower the blood pressure to help bring you back down in that more acceptable range. Something that's super helpful for PCPs is if you have a blood pressure cuff or like monitor at home, and if you were to like write down your blood pressures, in the morning and in the evening, every once in a while, they can get a much better idea of what your blood pressure looks like on a day-to-day basis, as opposed to just that one snapshot in time at the doctor's office. I think everybody can relate to the situation where you go into the doctor's office and the thing that's been bothering you, or like the rash that you have, just suddenly disappears on the day that you have the doctor's office, so it's kind of true for your blood pressure too. Just because you're nervous that day, your blood pressure might be super high, or the traffic was bad and you were late for your appointment. There's a lot of extrinsic factors that can affect your blood pressure on the day of your doctor's office visit. And so having that little journal of your blood pressures can be super, super helpful in knowing what it actually looks like regularly. And then taking your prescribed medication. So that statin that their primary care provider gave you to help manage your cholesterol, the blood pressure medications that they gave you to deal with that blood pressure. None of these things can help you if you're not taking them, unfortunately. So I know nobody likes taking pills. It's not fun. It seems like you don't need them. You're young at heart, and I appreciate that. And that mentality will take you far. But taking the medications is super, super important, so we can keep those things in check. And then that kind of goes along in the same vein as controlling your diabetes. So being mindful, if you are diabetic, what does your diet look like? What is your carb intake looking like? And are you being compliant, or, keeping track of your sugars and taking your medications as you're instructed, or as you're prescribed to? And then something else is that atrial fibrillation. You can't necessarily modify having atrial fibrillation or not, but being able to detect AFib, if you feel like, you're having episodes of dizziness and lightheadedness, and your heart's going super fast, and you're having palpitations, those can all be signs of AFib. But also many times atrial fibrillation is completely asymptomatic. Nobody, they have no idea whatsoever that they're in AFib. So just keeping in touch with your PCP, that's one of the ways to find out if you have atrial fibrillation. If they take an EKG, like a little snapshot of your rhythm, if they're just listening to your heart or feeling your pulse and feeling that it's irregular, they can set you on the trajectory of getting worked up for AFib and getting you on the right medications to help prevent stroke in the case that you do have AFib. So normally we would do the post test at this point, but I don't know if anybody has any questions, if there's a chat option that I cannot see, and if somebody would be so kind to read off any questions that might have arise. I'm sorry that I missed.
No, good. I don't see any questions in the chat, but please anyone speak up if you do. Was I just had a comment. I'm really amazed by the mobile stroke treatment unit. That's really cool. I did not know about that. That's pretty amazing. And I hope that it catches on and becomes more of a common thing across the country and the world, because especially with it being such a major problem with so many people having strokes every year. So that's amazing.
So, you know, as our population ages, these things are becoming more and more of an issue. And I think health systems are recognizing that. And I think it'll be more common in the future.
Yeah, yeah. And then I also just love that you encourage people to move. I know sometimes when people hear exercise, myself included, where you're like, okay, I didn't have time to go to the gym and do like an intensive class or something, but I did go for a walk after work because it was sunny out and warm today, and that's really good for us to do too. Because I think when we maybe make it a little simpler for people, it feels more approachable and more likely that they actually will do it.
Yeah, it's something I stress to all of my patients. You know, they're like, oh, well, I take my dog for a walk, and it's like, okay, that's great. Like that's
Yeah.
a starting point, and they don't give themselves the credit, you know, that they deserve. You know, you're getting your body moving, and that is what is going to help you the most in the long run. You know, some of the healthiest people that I have taken care of, I feel like they've all been like hikers. You know, they're just like to go in the metro parks with their dogs, and you know, they're not necessarily, you know, in the gym, you know,
right.
Iron.
I have met with a lot of like 90-year-olds who tell me, oh, I walk like 2 miles a day, because I always ask their secret for being so healthy. So I feel like walking is a good one.
Yeah, absolutely.
Does anyone else have any questions? Your presentation was great. I love that it was very thorough, but also very approachable for people to understand. I think that's really important in stroke education too, and having the Be Fast as something to keep in mind. I will be recommending this to like everybody to watch because stroke prevention is so important. So I'm sure people will be sick of me saying that, but I'll probably share it with all my coworkers too.
No, I feel that passion. So I appreciate that we share that. Yeah, so Be Fast is always something to keep in mind. And just, you know, even if you're wrong, that's okay. You know, you don't have to be completely sure to call somebody to get them evaluated. Because if you are right, you could be saving that person's life, and you could be saving that person's like functionality, which is huge. And even outside of stroke in and of itself, controlling all of those risk factors decrease your chances of like just general like small vessel changes, like little tiny injuries to the brain, which, you know, are not going to present as a full-blown stroke. You know, you're not going to have the whole face droop and everything, but you know, over time with high blood pressure, diabetes, and high cholesterol, those all cause like smaller injury to the brain, which can ultimately end up to being, you know, some cognitive deficiencies, and, you know, look like a dementia over time. So, you know, you're not only, if you're controlling those risk factors, you're not only preventing from full-blown stroke, but you're preventing from those little smaller like injuries that do eventually build up over time. So
Yeah, that's a really good point too, because it really can benefit you in multiple ways with all those preventative measures. Yeah. Well, thank you.
Oh, I'm sorry. I was
No,
gonna say,
please,
if
go
you
ahead.
go to your primary care doctor and ask for a sleep test, please. If you have sleep apnea, that's huge. Getting sleep apnea treated will help you in more ways than one. So please go.
I know. I was thinking about I know when I've talked to people about like I myself have high blood pressure, I will share that. And I'll go home and check it today. I haven't done it in a little while, so I take my meds though. But I always encourage people, you know, if you feel like you're having symptoms, it's okay to get checked out, but so many people are afraid to go to the ER or have EMS called. And do you have any suggestions for how to alleviate some of that fear?
Yeah. So I think just trusting your gut. I think a lot of us know when something's wrong, and it's really wrong. You're with that person every day. And if it's you yourself experiencing symptoms, sometimes people will call us thinking, I feel like I'm having a stroke. And you've never had this happen before. This has never happened before. Please just trust yourself and just give 911 a call, have somebody come and evaluate you. Because as many times as we have those false alarms in the emergency room, we also have many people that come through that are actually having a true stroke. So just knowing, we don't roll our eyes at people when they come in and it's not actually a stroke and it's just kind of like a false alarm. And thankfully it is, for us, that's the best case scenario.
Right.
Whether it's a TIA or a full-blown stroke or, a mimic of stroke, there are many mimics of stroke that could be happening as well. We're here to help people navigate through that. That's not your job as an individual to help to oh, do I need to parse this out? Let us do that for you. And that is what we're here for. That's what we're passionate about doing. So just know that if it's not a stroke, that's great. That's everybody's best interest. And if it's something like a TIA and your symptoms have resolved, we can work you up for why did you have that TIA. So things that we normally do in the hospital, if we don't exactly know why somebody has had stroke-like symptoms, we'll look at their heart with like an echo. So it's just like a little ultrasound probe to look to see if there's some sort of clot in the heart that's being thrown up to the brain causing stroke. We'll take a look at your heart rhythm. So put you on like a telemetry or get an EKG to see, is your heart rhythm regular, or do you maybe have AFib that you are not aware of? And we'll do, just different imaging and vessel imaging as well to see if you're having any sort of like stenosis or like kind of like kinks in your arteries here, so caused by like plaque and cholesterol buildup. We can image those to see if they're fairly open and allowing blood flow, or are they a source of little plaques flicking off and causing strokes. So there's lots of things that we can do, even in the event you haven't had a full-blown stroke, and we can optimize those risk factors, whatever it might be. So we get a second chance at it again and prevent it from happening.
I love that. We do have a comment that said, so informative and easy to understand. I am going to take a walk.
Great. I'm glad to hear that. I think there's supposed to be a snowstorm or something. I think I saw in one of the patients' rooms. So go for it now.
Go while we can. I know. I have a wellness walk thing in my office. Sometimes I just go to our parking lot and do wellness walks. So I'm going to think about that, especially now. It really is for wellness.
Yeah, I love the new trend of like the walker pads that people have been getting for working at home. They'll just like put the little underneath their desk and just walk while they're working from home. I think that's fantastic. I love that that's becoming like a trend. It's one of the things to get behind.
Yes, my brother works from home and he has one, and I'm like, that is amazing. Trying to see if I can fit it in my office, but we'll see. Well, thank you, Dr. Zales, for taking your time today to speak to us and to give us such wonderful information on such an important topic. We really appreciate your time.
Of course. Thank you so much for having me.
You're welcome.